I'm Dr. Karishma Tharyani, a practicing urogynecologist at Center for Urogynecology and Pelvic Health. The topic that I shall be discussing with you all today is surgical anatomy of the pelvis. Somehow, as we keep growing from being a medical student to a postgraduate and then as a practicing doctor, our knowledge of anatomy keeps fading. But it is one subject which needs to be revised at every stage of our academic career. So in this lecture, we'll be brushing through some basics of the surgical anatomy of female pelvis. So let's start. As we all know, that gynecologic and urological surgery is frequently performed using a vaginal or a perineal approach. Pelvic surgery requires a comprehensive knowledge of pelvic anatomy to safely attain access, maximize exposure, ensure hemostasis, and avoid injury to viscera, blood vessels, and nerves that exist in this area. So the aim of today's lecture is to study the anatomy of lower urinary and genital tract pertinent to a pelvic surgeon operating from the vaginal or perineal approach. But you will notice that at certain points in this lecture, we shall also be looking at the pelvic anatomy from the intra-abdominal approach, because it is very important to have a clear picture in your mind that's what the structures look like when you visualize them from above, and what the structures look like when you visualize them right up front of you. So we shall try to corroborate both of these findings and sort of unify this image for you in this lecture. The second aim of this lecture is also to understand the female pelvic organ support system with special emphasis on surgical anatomy. Because one of the most common surgeries which are done through vaginal or perineal approach are the reconstructive surgery. And you cannot really accomplish a good reconstructive surgery if you do not understand the pelvic organ support system. So with this background, let us start today's lecture. We know the pelvis consists of three bones: the ilium, the ischium, and the pubic bone. Very basic. Uh, all these the three bones, the ischium and the ilium, ischium, and pubis, are united, and bones on both sides, along with the sacral bone, unite to form the articulated pelvis. It is also important to understand the orientation of this articulated pelvis in a female. Now, in a female, in the standing position, the pelvis is placed in such a way that the anterior superior iliac spines on both the sides and the front edge of the pubic symphysis are in the same plane, that is perpendicular to the floor. This means that the pelvis is slightly bent downwards. Why is that? The bony arches of the pelvic inlet are oriented to almost a vertical plane. Now, what this orientation does to a woman? This orientation directs the pressures of the intra-abdominal and pelvic contents towards the bones of the pelvis, instead of towards the muscles or the endopelvic facial attachments of the pelvic floor. Now, had the pelvis been straight, like we see it in this figure, then you see this opening in the pelvis here. All the pressure would be directed down, and women would be more predisposed to having pelvic organ prolapse. But when the pelvis is directed in this fashion, the intra-abdominal pressure is directed towards towards the pubic symphysis, and this is a very, very important mechanism in a woman's body which basically prevents pelvic organ prolapse. Now, let us also understand some important surgical landmarks of the bony pelvis, since we are talking about the bony pelvis. One of the very important surgical landmarks in the bony pelvis is the ischial spine. As we keep growing up, we have studied many significance of the ischial spine in obstetrics and in gynecology. Let us revise certain important points with respect to the pelvic surgery. So we know that the sacrospinous ligament attaches to the ischial spine. The ischial spine is also the point where the white line exists. In paravaginal repair, the ischial spine can be palpated to identify the proximal location of the lateral vaginal attachment. That is, ischial spine forms one of the attaching points of arcus tendinous fascia pelvis. Don't worry, we'll talk about what arcus tendinous fascia pelvis is in the coming slides. When you have to give a pudendal block, you need to palpate the ischial spine. So these are few important points from the surgical perspective. One is in the paravaginal repairs, in the sacrospinous fixation of prolapse repair, and third, while giving pudendal nerve block to a patient. The next important landmark is the pubic arch, the upper and lateral border of the urogenital triangle under which the distal urethra and vagina exits. So pubic arch, again, we have learned its significance in obstetrics. But in gynecology, also the dimensions of the pubic arch play a very important role, especially if you're doing a non-descent vaginal hysterectomy and the uterus is big. So it is the dimension of the pubic arch which determines the success of this vaginal surgery. If the pubic arch is very narrow, you may have difficulty in delivering the fibroid or the uterus from the vaginal route. So this is again a very important landmark which should always be assessed in women in whom you are planning such a surgery. Next important landmark is the pectineal line. This is the pectineal line. This is the ridge along the superior medial surface of the superior pubic rami. Now, why is the pectineal line important? The pectineal line is important because it forms one of the attaching points of the Cooper's ligament. So, Cooper's ligament is an important point of suture attachment in birch colpus suspension. Now, in this era where the mid-urethral slings are now, the importance of mid-urethral slings is being questioned, and in many countries, mid-urethral slings are not being used anymore. Birch corpus suspension is the next surgery, which is very commonly performed for urinary incontinence. It is a very good time-tested procedure. Has a learning curve both in open and laparoscopic method, but has stood the test of time. So if you're doing a birch corpus suspension, you need to know the location of the Cooper's ligament. So Cooper's ligament attach on the pectineal line. Next is the obturator foramen. Now, obturator foramen is one of the few sites in the pelvis to which a gynecologist is not very well acquainted to, because we don't really come across surgeries which involve the obturator foramen. But again, with the advent of transobturator tapes, we started dealing with this area. Now, transobturator tapes, when they were introduced as a very simple, easy to do surgical procedure. They would say, you see one, you do one, you teach one. But little did we realize that when we look at a surgical procedure from this perspective, without actually understanding the intricacies of the anatomy of that area, it can lead to various complications. So it is very important to understand that this obturator foramen uh, is covered by the obturator muscle and the obturator membrane. And from its superior part, traverse the